Thanks, Louise, and thank you all for coming. First of all, congratulations to the new officers of the Texas Neurologic Society, some of whom are former trainees, and to Dr. Austin for her award. And thank you all for braving the icy roads to coming down here today. This is a clicker, I hope. So I'm giving this talk on behalf of my colleagues, Dr. Jose Miguel Yamal, who is the head of our data core, and Stephanie Parker, who is the project manager, put our mobile stroke unit on the road, and my colleagues Alex Zapp and Ritvij Bowery, who also share call on the mobile stroke unit with me. And as Louise said, our paper was published in the New England Journal in September. I'm going to talk and just give you a little bit of background about the mobile stroke unit, then about the data, and then main part of my talk is going to be whether we should have mobile stroke units in more communities than Houston. These are my disclosures. We're funded by the Patient-Centered Outcomes Research Institute to do this study and the American Heart Association. Genentech supplied the TPA for our trial, and I'm a consultant for Fraser Limited, which is a company in Houston that actually manufactures mobile stroke units. If we can go back a slide, please. Possible. I clicked too fast. Is that possible? Red button? Okay. I also want to, of course, recognize the other centers in our trial. This is a 7-centered trial, and there are now 20 some odd mobile stroke units around the country, 7 of which we're willing to alternate weeks so we could have a control group, and I'll explain to you how we did our trial. But these are the other colleagues in the other cities in the United States that participated in our trial and when they started. So why did we do this? So this is mobile stroke units. It's all about delivering TPA and delivering it faster, particularly in the first hour. So why is this important? This is a relationship from the Get With the Guidelines that can show you that the relationship between outcome on the y-axis and time from symptom onset on the x-axis is not linear. That within the first hour, if you can get treatment started in the first hour, there is a steeply increasing benefit that occurs from treatment in the first hour. And this is based on data that actually is back in the 1970s. Doctors Crowell and Ogeman at the Mass General put electrodes in primate brains and occluded middle cerebral arteries, and they found that you could keep the middle cerebral artery occluded for up to an hour and then reverse it, and there'd be no permanent damage. So, and then we know this from our imaging trials. When we do perfusion imaging in the first minutes after a stroke, we see large areas of hypoperfusion in green, but very limited regions of permanent damage when we see patients within the first few minutes after their stroke onset. In addition, clots are probably easier to lyse in the first hour. They're more porous. There's less fibrin binding within the clot. And so TPA and perhaps TNK can intercalate itself more within the clot and dissolve fibrin. So all the reasons why we may be able to get better results with treatment in the first hour. And the only way to do this is to get the treatment to the patient in a mobile stroke unit. Within our emergency departments, treatment in the first hour occurs in maybe 1% to 2% of patients. That's about it. So this is not a new concept. Tony Furlan, back in soon after TPA was approved, used to show this cartoon of a MRI scanner actually in the back of a van. We all laughed and said, well, this is nice, but we focused on our emergency department processes. But it wasn't until Klaus Fassbender in Hamburg, Germany, actually put a CT scanner in a Mercedes Sprinter. A picture on the left is Dr. Fassbender with myself and Silke Walter, who actually was the first person to actually administer TPA in a mobile stroke unit. And then the Berlin group used a larger unit and published their data that 30% of patients they could treat within the first hour, and compared to only 4.9% with standard management. And then earlier this year in JAMA, the Berlin group presented their data showing better outcomes with mobile stroke unit management with their mobile stroke unit. So that's kind of the background. We launched our mobile stroke unit in 2014. It is a plain old 12 foot standard ambulance, but the captain's chair is taken out, and the CT scanner is a Ceratom scanner put in where the captain's chair usually is. It goes back and forth on rails, unlike the gantry in your emergency department or in your CT scanner, which moves back and forth within the scanner. In this case, the scanner moves back and forth over the gurney. And we can get not only regular CT scans, but we can get CT angio on board of the Circle of Willis. And I'll show you more about that in a few minutes. And then, of course, after we arrive on scene, after we do the CT scan, we administer the TPA right there on scene. This is, and I don't know if I can do this, but this is a little video. Maybe I can't. This is a little video. Is it possible to click on this? Just shows you the our mobile stroke unit. Maybe not. Okay. Yes, if you just fast forward it a little bit, you can go a little bit faster if you click on the bottom. Yeah, there we go. We have a little computer in the front that connects us to the fire department, so we're in contact with the on-scene fire department, and we can determine if it's a patient who really is having a stroke. It's kind of low tech in the back. There's a regular standard fire department gurney. There's a CT scanner you can see. We are an ACLS unit. We can do everything. There's a defibrillator and a cardiac monitor on the left side. We have a telemedicine camera, I'll show you in a minute, that we can carry out the treatment either in person or by telemedicine. And we carry all of our drugs on board in a fishing tackle box, actually, you'll see in a minute. But not only the TPA, but all the other drugs we might need for control of blood pressure, including hematoma, hemorrhage reversal agents like Kcentra. So we're not the only mobile stroke unit in Texas. There's one in El Paso now that was launched in 2021, a larger, shinier, newer unit. But those are the only two in Texas right now. We can replace the neurologist on board, which initially was me all the time. Now is one of my colleagues I've mentioned, but we can also do it by telemedicine, and now most mobile stroke unit treatments are carried out by telemedicine, and we found that the accuracy of the physician on board is comparable to, or the physician by telemedicine is comparable to the accuracy of the onboard clinician, and furthermore, that our time to treatment is just as fast with telemedicine as it is with on-person. This is an example of a patient, how we speed the entire process. So a 65-year-old man, symptom onset at 10:30 in the morning. We get dispatched along with the fire department. We rendezvous with the EMS ambulance, in this case 37 minutes after the patient's symptoms started. You can see he had a high NIH stroke scale score. We got a CT scan, was normal, so we gave this patient TPA 47 minutes after symptom onset. Then we carried out the CT angio. You can see that the patient had a left middle cerebral artery occlusion. So we call ahead to the endovascular suite, and we're able to get groin puncture 10 minutes after arrival in the emergency room, just 111 minutes after the symptoms started. So the process is much speeded, and of course, I'm only going to show you good outcomes, but this patient had a thrombectomy and did very well. But the point is, this is the sequence of events that occurs when we get alerted rapidly. So what were the results of our trial? We had two main objectives. One was to look at the usual 90-day rank and score outcomes that we look at in clinical trials, and the other was to follow everybody for a year and look at their healthcare utilization. This was we're not allowed to randomize. Our fire department medical director would not allow us to arrive on scene with the mobile stroke unit and then not use it. So he said, you can't do that. So the only way we could develop a control group was to have alternating weeks where the mobile stroke unit was on one week, and the next week we did not. We were still alerted, but we didn't deploy the mobile stroke unit. Our nurses would just go out and meet the fire department on scene and determine if this was somebody that we would have treated on the mobile stroke unit had it been on. And we did this in all 7 sites for several years, and that's how we got our control group. it's not logical that we would help patients who did not get TPA. I'll show you our data in the total cohort as well, but our main population of interest were TPA eligible patients. And we looked at the 90-day Rankin score, but we used the utility weighted Rankin score, which is where each Rankin score, and for those of you not familiar with the Rankin score, it goes 0 to 6, 0 or 1 meaning no disability, 6 is death, 5 is totally disabled. But patients weight those different transitions differently. So for a patient, a difference between a Rankin score of 3 to 4 is the ability to walk independently. And patients would weight that transition much more than they would a Rankin score of 0 to 1, which is having no symptoms versus a little bit of numbness in their hand. So we use the utility weighted score as our primary outcome. And a utility weighted score greater than or equal to 0.91 actually is equal to a Rankin score of 0 or 1, meaning totally independent. So the way this would work is a 911 call comes in, the fire department ambulance gets dispatched. If it's a stroke call, we get dispatched as well. We communicate with the fire department on scene, arrive on scene with the fire department, determine is this patient having a stroke? If so, we load them in the mobile stroke unit. If not, the fire department just goes on without delaying their management and takes the patient to the hospital. On standard management weeks, as I pointed out, we did the same thing, but we did not dispatch the mobile stroke unit. Instead, our team would go and meet the fire department. And then all patients that were enrolled were adjudicated by a neurologist who did not know which group the patient was in, did not know whether they got TPA treated, to determine if they were eligible by guideline criteria. And that became our primary outcome group. And then, of course, our 90-day outcomes were also assessed by a person who was blinded to treatment allocation. All of this to eliminate any possible bias. So in the trial, we had 10,000 alerts by the fire department in order to enroll about 1,500 patients. Actually, 1,500 patients were enrolled and transported on the mobile stroke unit, of whom about 1,000 were eligible, so about 10%. So that's pretty much the same we see, about 10 alerts for every one patient we actually treat with TPA. And this treatment rate would vary anywhere from one patient every day in Houston to one every 3 days in some of our other sites. So we'll come back to this in a few minutes. And only 3% of our patients were lost to follow-up in each group over the course of the next 90 days. There's a busy slide, but I just want to show you that these were serious strokes. The average NIH stroke scale score was 9, but a third of our patients had NIH stroke scale scores over 13, which represented large vessel occlusion patients. We had a large percentage of African American patients, Hispanic patients, so we had a large amount of wide range of patients enrolled in the trial. And also 25% of the patients we enrolled in the trial had pre-existing disability. If we arrived on scene and the patient already had a stroke and had some disability, we still would enroll them in the trial. This is different from most stroke studies, which only enroll patients who did not have a baseline disability. And it's important when we talk about cost effectiveness, if a patient's already in a nursing home and we treat them, they're not going to do any better, so they're still going to wind up with chronic long-term costs. So it just figures into when we do our final analyses of that. So we did save time on average from last known normal to TPA treatment. The average time was 72 minutes compared to 108 minutes by standard management. So I just want to point out that our standard management group was pretty good, right? That means the average time from symptom onset to treatment with standard management was still only less than 2 hours, 108 minutes. And we shortened that by 36 minutes. But interestingly, we did not speed endovascular therapy, and I'll come back to that in a minute. Some of our patients, about 20%, would go on to have endovascular therapy. You'd think we would speed that. We didn't, and I'll explain why in a few minutes. This slide shows you the distribution of time from symptom onset to TPA bolus in the mobile stroke unit group on top. compared to standard management on the bottom. And the most important difference, of course, is in the first hour. You could see that 33% of the patients we treated on the mobile stroke unit got treated in the first hour compared to only 3% with standard management, and an overall shift to the left of earlier treatment with the mobile stroke unit. Not only that, interestingly, more patients got treated who should have been treated on the mobile stroke unit than with standard management. So 97%, is remember that all the patients that were enrolled were adjudicated by a vascular neurologist who didn't know which group the patient was in, looked at the patient's clinical characteristics, looked at whether they were TPA eligible, and determined this is a patient that should have been treated with TPA, was TPA eligible or not. And of those patients who were adjudicated as TPA eligible, 97% of them got treated if they were in the mobile stroke unit group, but only 79% of them got treated if they were in the standard management group, which means that 20% of patients who should be treated don't get treated in our emergency rooms by standard management. And we know this, right? I mean, when it's not just a matter of time, it's that our infusions get stopped prematurely for reasons that are unnecessary, or the treatment doesn't even given in the first place. And we can discuss why those reasons are. So these are our outcomes. The utility-weighted Rankin difference was significantly different in the mobile stroke unit group. These numbers probably don't mean much to me. If you look at the median utility-weighted Rankin score, I pointed out a 0.91 or higher represents a Rankin score of 0 or 1. And you can see the median score actually in the mobile stroke unit group was just exactly at around 0.9 compared to the standard management group on the right. And if you look at the distribution of Rankin scores, the way we usually look at them, you can see the lighter colored bars are a Rankin score of 0 or 1. The darker bars meaning worse Rankin scores or worse outcomes. And you can see the mobile stroke unit group on the top compared to the standard management group on the bottom had a better distribution. Many more patients ended up with good outcomes and fewer ended up with bad outcomes. And no matter how we analyze these data, became highly significant in favor of the mobile stroke unit. In addition, as I showed you with one of my first slides, the action was all with treatment in the first hour or so. This shows again on the y-axis the percentage of patients returning to normal, and on the x-axis the time from symptom onset and the nonlinear relationship. You can see that at 90 minutes appears to be the tipping point. You get patients treated within the first 90 minutes, and certainly within the first hour, you get much, much better results. And in fact, if you calculate that patients with pre-existing disability and calculate how often they return back to their baseline state, 68% of patients treated in the first hour got either completely recovered from their stroke or got back to their pre-existing state. So 68% of patients recovering with treatment in the first hour is pretty potent. And you can see these relationships were highly significant. One of the concerns about mobile stroke unit treatment, if you're speeding up the treatment so fast, how accurate are you? Are you treating patients with TIAs? So we, of course, looked at the final diagnosis of stroke in our patients, and there were stroke mimics occurred in 9% of the patients we treated on the mobile stroke unit, but also 9% of the patients in the standard management group. So there was no lack of accuracy by treatment on the mobile stroke unit. And if you look at patients, there were more strokes reversed by TPA on the mobile stroke unit where the patients got better. But I will show you in a minute, even if we looked at the data in just the patients who had definitely imaging positive, MRI positive strokes, there still was a difference, strong statistically significant difference in favor of the mobile stroke unit group over the standard management group. If you looked at all transporting patients and say, okay, fine, you do better with, but we transport some patients who turn out to have hemorrhages and some patients who turn out to have mimics, does that whole group benefit? And the answer is yes. In the overall group transported by the mobile stroke unit, there's still a benefit, but it was driven by the TPA treated patients. Because if you look at the non-TPA patients alone, just the hemorrhages and the non-TPA treated patients, there wasn't any benefit. And you wouldn't expect, why would a mobile stroke unit substantially help a patient with a hemorrhage? At this point, we don't have an effective treatment for intracerebral hemorrhage, so you wouldn't expect there to be different. But so the positive results were driven entirely by patients we treated with TPA and by faster treatment with TPA. So putting this in perspective, the difference we saw in the utility-weighted Rankin score was only slightly less than what was seen between TPA and placebo in the NINS trial. And if you look at the effect of TPA between 3 and 4.5 hours, the utility-weighted difference would be 0.03 compared to the 0.07 that we found, so much more powerful than with a delayed treatment with TPA versus placebo. And another way to look at it is for every 100 patients we treat on the mobile stroke unit, 27 would have less disability and 11 more will be completely disability-free. So the conclusion of the study is that compared to standard management, 17% more get treated with TPA. I think that's a very important fact. And not only that, 30% more get treated within the first hour. Those two facts drive the beneficial benefits, which mean that there were significantly improved patient-centered outcomes, 10% more completely recovering, and these results were also positive in all transported patients, and there were no safety issues. But I'll tell you more about healthcare utilization in a minute and cost effectiveness. So let me turn my attention now to the more practical question, is whether you need to have a mobile stroke unit in your city. This is the editorial that accompanied our paper by Ken Lees in Glasgow. He asked the question was, does my district or county or city need a mobile stroke unit? So let me discuss the issues that would come into play in that decision. What about cost effectiveness? Is the results of our study replicable? What about endovascular therapy? How large a city do you need to make a mobile stroke unit worthwhile? Is it important for credentialing? How do you get mobile stroke units credentialed? And what are the keys to making them efficient? What about their use in rural areas or cities? And can they be used for other things? So we're going to touch on those things in the next few minutes. Well, what about cost effectiveness? Our cost effectiveness study, if I were giving this talk next week, I'd be able to give you the results. We're presenting them at the International Stroke Conference in a few days. I cannot tell you the results, but I can tell you that the Berlin group did their cost analysis and came up with a 41,000 euros, or about $45,000 for each quality adjusted life year obtained. That means the expenditure of a mobile stroke unit is about $45,000 in order to give one more year of disability-free life, which would be considered highly cost-effective under most considerations. And that's, of course, taking into consideration the downstream benefit against the upstream cost of buying a mobile stroke unit and putting it into operation. Are our results replicable? This is a meta-analysis that has just been published of all mobile stroke unit studies. You can see, if you're used to looking at these, that there's a consistent benefit in all of the studies. If you look at the percent obtaining a Rankin score of 0 or 1, and furthermore, if you look at the shift analysis of any benefit, again, in all of the studies, all showing a favorable outcome. The European Stroke Society has just published their guidelines about mobile stroke units. They've just revised them on the basis of these studies, and they concluded that in patients with acute ischemic stroke, pre-hospital management with a mobile stroke unit improves functional outcome, increases the rate of treatment, including the rate of thrombolysis within the golden hour, shortens onset to treatment, and the quality of evidence is moderate. And they make the point that including a specialist neurologic expertise, either in person or by telemedicine, is essential. And their overall recommendation is that they suggest the use of mobile stroke units over conventional care for the pre-hospital management of patients with suspected stroke. my own bias is when you say what's moderate, it all depends on what kind of screen you're looking at, but I would argue that if probably I asked most of the people in the audience to raise their hand, if they had a stroke or their family member had a stroke, whether they'd like to have a mobile stroke unit come to their door or a standard ambulance, most people would probably say, based on the data, they'd want a mobile stroke unit coming to their door. They may not want to pay for it, but they would probably rather have the mobile stroke unit there. So I think if you are going to use the traditional Heart Association criteria, our trials were not strictly randomized by patient. They were cluster randomized, so they don't meet the 1A criteria, so they probably would be a 1B criteria. With regards to thrombectomy, we did not, as I pointed out, speed thrombectomy. I'll explain to you why in a minute, but some of the studies did speed thrombectomy, and those that sped thrombectomy did CT angio on board the mobile stroke unit. I pointed out that we can do CT angio on the mobile stroke unit, but during our trial, it was not routinely done in our large stroke patients. It wasn't until fairly recently that most of our centers started doing CTA routinely. When CTA was done routinely in the trials where it was done routinely, they did speed thrombectomy. And Dr. Zapp has shown that when we do CT angio on the mobile stroke unit, and then we can, as I pointed out in that first slide, forewarn the emergency department and the endovascular teams so they're ready, then we speed endovascular therapy by about an hour. But what happened during the trial when we didn't do CT angio is we would speed TPA, then we'd get to the emergency room, and the patient would have to have their CT angio done in the emergency room, so there was no shortening of the time to thrombectomy. Incidentally, this is a CT angio showing an M2 occlusion, showing you the type of quality of CT angios we can get with the serotonin on board the mobile stroke unit. So what about how large a population you need? Our mobile stroke unit has a catchment area of about 1 million in Houston, and we treat about 200 patients per year. By the way, about 10 to 15% of all the strokes in Houston treated by TPA is treated by our one mobile stroke unit, which is only on for 10 hours a day. So our catchment area is about 1 million, and the average, just to put that in perspective, our average Houston area stroke center treats about 40 to 50 patients with TPA a year. We treat about 200 per year. So proportionally, an efficient mobile stroke unit covering, half of the area or a third of the area that we cover would be just as busy as treat 40 to 50 patients, about the same number as a regular primary stroke center does. So if you're trying to figure out, well, is it, busy enough? Another way to look at it is the cost. Our operating budget is about $1 million a year in terms of salaries and all the rest, and we transport about 330 patients a year. So given the fact that for our million population, we would need to get about $3,000 per transport reimbursement in order to meet our operating costs. A less busy mobile stroke unit would have to get proportionally more reimbursement. Well, for reference, the DRG payment to a hospital for TPA is $11,000. Right now, CMS does not reimburse, Medicare does not reimburse for mobile stroke unit transport. There just is not a pathway. In 2 weeks, we have another discussion with CMS to try to establish a pathway for both TPA administration and transport on a mobile stroke unit so we get reimbursed. But it's perfectly reasonable to think that a mobile stroke unit would get reimbursed $3,000 for transporting and treating a patient with TPA, and perhaps probably even more. 80% of the patients in the United States live within a 60-minute drive of a stroke center. In my opinion, most of those patients would benefit from a mobile stroke unit. I think 350,000 is probably the minimal population that you need for a mobile stroke unit, 350 to 500,000 catchment area. Well, I just put up the population of some of our smaller metropolitan areas in Texas. Obviously, Houston, we project we need 3 or 4 mobile stroke units to cover the whole Houston metropolitan area, and probably the same for Dallas, a little bit less in San Antonio or Austin. But Corpus Christi has 350,000 people. Tyler, Longview, Kilgore, 350,000. You can see McAllen has 870,000. El Paso, of course, has a mobile stroke unit. So it gives you an idea of the communities in Texas that probably can sustain mobile stroke unit in terms of the population. Now, a mobile stroke unit is a stroke center. Basically, we do what a stroke center has. We're thinking that we should be designated as a stroke-ready hospital, and we get rid of this whole issue of drip and ship. So we don't have to worry about a patient, should they go to a primary stroke center or should they go to a comprehensive stroke center, because we are a primary stroke center. So we treat the patient with TPA. If they have a LVO, they go to the comprehensive stroke center. They don't have a LVO, they can go to the nearest hospital. It's just not an issue. So it gets rid of that whole dynamic of whether the patient should be dripped and shipped or taken directly. Another question is that with mobile stroke units occurring, we have comprehensive stroke centers. So should mobile stroke unit or pre-hospital management be integrated with our certification process of our comprehensive stroke centers? Some point in time, if it's better for patients, outcomes are better. If you're going to have a comprehensive stroke center, maybe someday you'll need to have a mobile stroke unit as part of your comprehensive stroke center pre-hospital matrix. Right now, you cannot be a stroke center unless you already have a plan for interaction with EMS, or if you're a primary stroke center, transporting your LVO patients to a comprehensive stroke center. If you're a comprehensive stroke center, you have to have an arrangement with EMS to receive such patients. Well, maybe at some point that'll also include mobile stroke unit. Now, there are certain keys that are essential for making mobile stroke units work. They don't work if it's one hospital system that develops a mobile stroke unit just to get patients for their own hospital. The way we treat 200 patients a year is we deliver patients to all the hospitals in the city, regardless of whether they're Memorial Hermann Hospital patients or Methodist Hospital or St. Luke's or HCA or Harris County. So if we arrive on scene, the patient's already established at Methodist, they go to Methodist. If they're already established at Hermann, they go to Hermann. And if they're not established, we rotate. And this is a process that's was actually established right at the outset in collaboration with the fire department and with the directors of all of our stroke centers. So this is the way it has to work. And it also doesn't work if you work just with one EMS system. So in some cities, like in Denver, the Aurora, Colorado, and so their EMS is staffed by Aurora Fire Department people. Well, the Denver Fire Department won't allow that ambulance to pick up a patient in the Denver Fire Department catchment area. It just makes no sense. There's more politics, or just as much politics and turf in the EMS system as there is in the rest of the world, and that you have to get past that. So in Houston, we have all the fire departments in the city collaborating with. We're alerted by any of them, and we pick them up. So if you're going to set up a mobile stroke unit, you need to work with your fire department and with all of the stroke centers in your community collaboratively in order for it to work. And in fact, probably, I would argue in Houston, there's probably not a better example of collaboration among our stroke centers and among the fire departments than with our mobile stroke unit. By the way, there's a picture of all the directors of our mobile stroke units. The other key to efficiency is rendezvous. If we get called, our catchment area is really just 8 miles. We're located in one central location, and we're dispatched from that location. But if somebody has a stroke out by the Beltway, 20 miles out from the medical center, and the EMS is going to bring the patient to a comprehensive stroke center that's a lot closer, we can rendezvous. They never delay. They never wait on scene. We don't allow the fire department to delay their management. So if they're ready to depart the scene, we'll meet them halfway to the comprehensive stroke center and treat the patient in a parking lot somewhere. We do that all the time. And in Edmonton, Alberta, where there's a mobile stroke unit, they get patients brought in from 200 miles away. They'll meet them 100 miles halfway and treat the patient halfway, they still save a substantial amount of time. So Rendezvous is a very efficient way, and it extends our catchment area actually in Houston out to 13 miles on average. And half of our patients were treated by Rendezvous. So does this work what about in congested areas? In New York, they have a mobile stroke unit. There's the old saying, if I can make it in New York, I can make it anywhere. Well, their mobile stroke unit was put out of commission during COVID because they had to utilize their nurses and their medics for other things. But when they were in operation, 1.4% of their dispatches were strokes in 1 year, and 14% of their stroke alerts they treated. And remembering, if most of you, I'm sure, have been in New York and gone to apartment building, it takes a long time to negotiate. If you have a stroke in an apartment building in New York, it may be 3 blocks from the hospital, but it still may take you an hour to get from your apartment down to that emergency room because of getting the ambulance to your apartment, getting upstairs, getting the patient extracted downstairs, and then back to the emergency room. And that can be shortened by the mobile stroke unit. And in rural areas, I mentioned the Edmonton, Alberta mobile stroke unit. There's one in Saarland, Germany. That's where Klaus Fassbender, the first mobile stroke unit, is located. It's the most rural part of Germany. And he found that even out to at 10 miles was sort of an optimal operating distance for cost efficiency, but even out to 26 miles, it was cost efficient because of the Rendezvous thing and as the Rendezvous method. And if they had a population density of 274 inhabitants per square mile, that was kind of the tipping point for their cost efficiency. So if we need more data in rural areas, but I do think it, for the reasons I mentioned, can also be useful in rural areas. Clearly, if we had other diseases or other conditions that would benefit, it would increase the utilization and the efficiency of mobile stroke units. So we are now about to launch. In fact, we have launched another study of factor 7A, recombinant factor 7A, to stop bleeding in patients with intracerebral hemorrhage. The difference between this study and the one that was done before is that, as with everything else, we're moving the treatment faster in mobile stroke units within the first 2 hours of symptom onset. If we can show that we can arrest bleeding with intracerebral hemorrhage by mobile stroke units and give it yet another disease condition that it would be useful for, then obviously it would increase enthusiasm for the use of mobile stroke units. That study is just getting started. So in summary, I think mobile stroke units do improve outcome, mainly by increasing TPA treatment and speeding it into the first hour. They're probably cost effective. Tune in to our talk next week, but on all of the data from I've shown you, including another study I didn't show you from Australia, everything does point to cost effectiveness because of reduced downstream costs. They qualify, I think, for Class 1B status and practice guidelines. I think a population of 350 to 500,000 can probably support a mobile stroke unit. The optimal utilization of a mobile stroke unit requires collaboration of all EMS agencies and stroke centers in the community. I can't emphasize that enough. They probably are useful and cost effective in rural areas, but that requires further study. And it may improve outcome in other conditions, which would certainly increase their utilization, particularly intracerebral hemorrhage. And I do think that they do speed endovascular therapy, but we do need more data on that particular issue. So with that, I will stop. I'll just point your attention to we do have an international organization of mobile stroke unit centers called PRESTO, the Pre-Hospital Stroke Treatment Organization, and these are the mobile stroke units currently existing in the world. There's 30 some odd, with 21 in the United States. And with that, I'll stop and be glad to answer any questions. And once again, thank you for coming to brave the elements in Austin today. Questions?
Dr. Grotta, thank you for an excellent talk. There's an increased movement that stroke is a social disease. And one of the things people talk about is patient recruitment in a lot of trials and the diversity of patients we see. I think one of your slides on the demographics just highlighted how you have a good representation of, say, Hispanic patients and patients from ethnically underrepresented groups. Did you see a difference in the outcomes for these patients when treated on MSU compared to if they would have conventionally presented to an emergency room?
Well, we did look at, one of our pre-specified things was to look at race, ethnicity, and gender differences in MSU versus standard management benefit, and there was no difference. There was no heterogeneity in effect among that. What we did see, and what we'll report, is that cost effectiveness may differ only because of downstream healthcare utilization, as you know, does differ in different ethnic groups, right? So there's less downstream utilization, and it largely has to do with socioeconomic issues, and that would impact cost effectiveness. If people don't go to a nursing home or wind up in nursing homes more frequently or don't, that in a certain group, that might affect their cost benefit, well, in that particular group.
Perfect. Thank you.
I don't know if that makes any sense.
Quick question, but if a city wanted to put together a mobile stroke unit, where would you advise them to start looking for funding? I mean,
Yeah. Well, first of all, if we are successful in getting CMS to reimburse us, then the hospital would pay for it, and then over the course of the next 5 years, their outlay would be amortized and recovered by their transport fees. So at the end of the day, that has to happen in order to make this a widely. And I think that will happen, just like anything else. But right now, there's just a vacuum. These pathways just don't exist. And but almost every mobile stroke unit that's gotten started has been funded by philanthropy. And they cost about $1 million, actually about $900,000. Now remember, a regular ambulance costs about half that, right? So the main added cost is the CT scanner, which is about $400,000. Point out that an MRI scanner in your hospital costs $3.5 million. So the $1 million for a mobile stroke unit that can treat 100 to 200 patients a year, and for 5 to 10 years might be a reasonable cost outlay for your hospital compared to other costs, other things that they spend their money on. Right. It's salaries and TPA. I mean, there is no billing pathway for TPA on a mobile stroke unit. I give TPA in a clinic or the emergency room. I can bill and recover my costs. I can't do that because right now, right this minute, there's no pathway or a billing pathway for TPA on a mobile stroke unit. Now that's absurd. We're changing that. That will change at some point in time, but it hasn't changed yet.
Now, just a quick follow-up to Sarah's question. For districts that may be low on cost, can you equip an ambulance that they already have and just pay the extra $400,000, or do you have to build it out new?
Yeah, there have to be certain safety criteria built into the anchoring of the CT scanner, but it rests on a standard chassis and a standard ambulance. It would be easier just to buy one from the start, but most of your EMS agencies are constantly recycling and buying new ambulances. So it can be a regular standard ambulance that they buy with a few tweaks added and a CT scanner put on.
When you look at cost effectiveness, can you teach EMS the ability to run the CT scanner, avoiding additional personnel costs?
Good question. Actually, the training of a CT tech is longer than the training of a medic. So the logical thing would be to take your CT tech and train them to be a medic and be able to drive the rig. Not necessarily a medic, but an EMT. All you need to have to drive. We have two, usually when we do this by telemedicine, we have two, a medic and an EMT. Medic in the back to help the nurse managing the patient, and an EMT to drive. Well, you can train your CT tech actually to be an EMT, and they'd be able to drive the unit. The CT tech is very important. You'd think that this CT scanner would be very fragile and would break down, particularly in Houston with all the potholes. Fact is, we've had very few days that we've had the CT scan not work, and that's because our CT scan tech takes good care of it like their baby.
And I think you might have already answered this. Have you created a pathway to get recognition from CMS as a facility provider? That's what we're trying to do now as a point of service. How did you overcome the radiation concern from CT?
An excellent question. We had to have all sorts of licensure that we have to go through, including radiation safety. So there is no problem with radiation safety. We measure it within of course, when we do the CT scan, we go outside. The CT radiation for the patient is the same as it would be in the hospital. For the staff, we stand outside the CT scanner unless the patient has, for some reason, needs us in there, in which case then we lead up just like we would do and we all wear radiation badges, but to measure the amount of radiation. But this is carefully monitored by our radiation safety folks, and we've measured it. In fact, we've published our data that there is no increased radiation safety concerns. And it's time for lunch. I hate to be the last person to stand between us and lunch, so I will make sure we finish early. Thank you again.